Welcome to the Tenex Health Educational Webinar Series. Shortly, our invited physician will begin their session.
Hello, my name is Michael Budler. Thank you for joining us this evening. We're going to talk about how to develop your Tenex Health practice. A little bit about myself. I have to disclose I am a consultant and have financial interest with Tenex. I'm an interventional radiologist at Bryan Medical Center in Lincoln, Nebraska. Went to med school at the University of Nebraska Medical Center. Did my radiology residency at University of Kansas. Did an IR fellowship at University of Oklahoma in Oklahoma City. And I came back home. I was born and raised in Lincoln, actually. So about our practice, Advanced Radiology is the name of our group. There are 4 fellowship-trained interventional radiologists in our group. We just had one join us this July. Strictly private practice. We're 100% IR every day. And we do provide coverage for a large footprint in Nebraska. We cover Omaha, Lincoln, Fremont, Grand Island, Kearney, and used to cover North Platte, but we dropped that this year. So procedures that we perform, we do perform a gamut of IR procedures. The outpatient procedures consist of busy vein practice, where we perform laser ablation, microthrombectomy, sclerotherapy. We do a lot of pain management injections as far as epidural steroid injections, facet injections. We do venous access, portacatheters, central lines, tunnel hemocast and kyphoplasties, sacroplasties, and then all the CT and ultrasound-guided biopsies and drainages. And we recently added a sphenocatheter for sphenopalatine ganglion blocks, which can treat migraines and cluster headaches. Inpatient procedures consist of stroke therapy, where essentially the intra-arterial stroke team from Lincoln. We perform DVT lysis and thrombectomy with the trellis, IBC filter replacement, removal. We also do biliary procedures, nephrostomy tubes, RF tumor ablation, G-tube placement, uterine fibroid embolization, testicular vein embolization, pelvic congestion syndrome treatment, dialysis work, TIPS, trauma, and angioplasty and stenting. The Lincoln practice consists of Bryan Medical Center East and Bryan Medical Center West. Together, there are about 600 beds. We average 15 to 20 procedures a day. All procedures are hospital-based. And we do have our clinic, which is in the specialty clinic at both hospitals. So why did we get involved with Tenex? I have to give Dr. Troy Long, a very good friend of mine, credit. He's an interventional radiologist in the Twin Cities in Minnesota. He, being a very tech-savvy city, he heard about Tenex before I did, gave me a call, explained that there was an ultrasound-guided, minimally invasive outpatient procedure, a very safe technology. Ophthalmologists have been using ultrasonic needles in eyes since 1967 safely. And so it bears out that it's been a very safe needle in tendons and plantar fascia. The results have been great. This was a really nice way to build your practice. And personal experience, I've actually had an episode of plantar fasciitis, so I know exactly how my plantar fascia patients feel. And so we thought that we definitely needed to get Tenex on board. So at the time there were 3 interventional radiologists, and so it took us all about 15 minutes to call the other 2 partners, and we decided, yeah, we definitely have to get trained. I was the first hire in the country to get trained to do the TX1 tenotomy, and also the first physician in Nebraska to use the microtip. We became an official center of excellence, the only one in Nebraska, and we enjoy training other physicians from all over the country. So this is a very common problem. There are over 10 million chronic tendinosis patients per year in the United States. 2 million patients in the elbow and the shoulder. That's tennis and golfer's elbow together. 3 million patients per year have plantar fasciitis or Achilles tendinosis. And then the knee, there are only about 500,000 patients. So percent of cases completed, 35% have been elbow, 35% have been plantar fascia, and 12% have been Achilles, 13% in the knee, and the shoulders 5%. I think that number will be going up when the longer needle is available for us to use. So patient selection, patients are usually having chronic pain, which we consider more than 3 months in the affected joint. They're usually not responsive to conservative medical treatment, which would consist of rest, ice, bracing, physical therapy, steroid injections, and NSAIDs. You'll see a lot of patients that come to you, they'll just have a laundry list of things that they've tried. Point tenderness. This is also a very straightforward thing that you'll see on the physical exam, where you'll just put your finger on the one point and you can identify exactly where the pain is in that tendon. It's very straightforward. Ultrasound confirmation. The ultrasound is placed over the tender region, and you can see the hypoechoic focus of degenerative tissue and thickening in the tendon right on the ultrasound. The reason you can see it is there's proteoglycans in this mucoid degenerative tissue, and there's increased water in this, which is thus why it's hypoechoic. So we have ultrasound-guided tendon treatment. The problem, obviously, in this degenerative tissue is there because of either overuse, causing this damage or necrotic tissue, which causes pain, limits motion. It's also slow to heal. You can also this can also be secondary to a traumatic injury to this area as well. We've seen that. But current treatments are very underwhelming. Cortisone injections are not really helpful. There's actually some masking of the pain, and it can damage and actually atrophy the tissue while surgery is being put off and avoided by the patient. So it's actually controversial whether cortisone injections should even be performed for these patients. The solution is very simple. We can replicate the surgical approach of removing this damaged tissue, but we can do this in a very minimally invasive manner using an ultrasound-guided system and the TX1 ultrasonic needle. So percutaneous tenotomy or fasciotomy with a TX1 device involves, one, visualizing the damaged tendon. It's usually hypoechoic and thickened. There's often irregularity of the cortex or detaches. Simply numb up right through the degenerative tissue, usually numb up right down to the bone. make your nick in the skin and then guide your TX1 microtip through that damaged tissue and activating the microtip with the foot pedal, you can precisely cut and debride that damaged tissue. You can see that endpoint as well because it becomes less hypoechoic and more hyperechoic through the cavitation and the microbubbles, which are increased in echogenicity. Post-operative care, we usually have our patients ice it the first 24 hours. We usually have them actually use heat twice a day because we think that it increases blood flow to the area and helps with the healing. They are to really baby that area and decrease their use of that area for the next 2 to 4 weeks. They do get a low-cut air walking boot, which for the Achilles and the plantar patients, we want them to wear that for 2 weeks at a minimum. They can then go to their most comfortable shoe after the 2 weeks. If they still have pain, we tell them not to hesitate putting the boot back on and wearing it as long as they need it. Elbows, we like to keep the full range of motion. They get a little sleeve when they leave, but there's no sling. We want them to keep that elbow moving in the full range of motion, so we don't want to get a frozen elbow. At 4 weeks, they can progress to their moderate activity, with the full activity usually in about 8 weeks. Initially, we had a clinic visit at 2 and 8 weeks. We have since changed that to seeing them at 4 weeks, where we evaluate for pain, any complications such as infection or hematoma, wound healing, and also evaluate the range of motion. Results, we see patients at 4 weeks. They have about 50 to 100% decreased pain from baseline at the 4-week point. We did have to retreat one plantar patient. I think that was a patient earlier where we were more concerned about how much time we were using the ultrasonic needle. Not that you should be concerned about that, but I think the thing that we learned was stay in as long as you need to take out that degenerative tissue, because it is a very safe needle. She was having pain right along the edge of the plantar fascia, and when we looked at with the ultrasound, that's exactly where a little bit of the tissue was left in. We took that out. She had no pain after that. So we learned that you just stay in and remove that tissue completely. And then we had one plantar and one common extensor that went on to surgery because they just didn't want to wait. I think they had a little more severe disease, and I think that's where you need to really be just a little more patient, because 85 to 90% of these Tenex patients are pain-free after the procedure. We have done a 1-year plantar kind of retrospective study. Our data shows using a pre and post ankle hindfoot scale. In the 70 patients that we have that are more than a year out, we've had 44 responses, and this is ongoing. The 47 was the average points for the patients on the pre-Tenex, and then 87 was, out of 100 points total, was the average points post-Tenex. And so that was a definite gain in decrease in pain. Oops, sorry about that. So there's a list of the published and accepted as well as the submitted articles that show that around 90% of patients they're pain-free within 6 weeks of treatment. and they don't need additional treatment. This minimally invasive procedure is well tolerated and has been very safe. There has not been a single tendon or plantar fascia rupture in over 15,000 cases performed in the United States over the last 2 years. I'm sure you're able to get these studies from your reps if you just ask them. Talk about our Lincoln experience. We started in November of 2012. We've performed 312 Tenex cases listed as follows: 197 plantar. We have done 58 Achilles, and then fewer elbows, 43 lateral, common extensors, and then 12 of the common flexors, and then 2 patellar. So as a group, these are our numbers. We've performed 406 Tenex cases in Nebraska, and I've done 286. Alan in Grand Island has done Grand Island and Kearney, 89, and Himmelberg in Lincoln and Fremont, 21, and then actually Dr. Pfeiffer just joined us, and he already has 10. How do we get to patients? We did follow our vein model. We have, I think a robust marketing effort in place with our varicose vein model. So we just inserted Tenex into that, and we'll talk about that. And we're aggressive at our marketing. We teamed up with the hospital. That's helped defray our costs. You can cut your cost of marketing in half if you can team up with your hospital. Websites, we're able to get information on the hospital as well as our website about our procedures. And then we did target orthopedic surgeons, physical therapists, and primary care physicians, specifically the internal medicine and family practice docs. So we broke it down into direct patient marketing. We use newspaper ads. A lot of people in the Midwest still read newspapers. And there's a women's edition magazine that's been a very good vehicle for the marketing. The women's edition magazine is found pretty much in any waiting room, whether it be a beautician or a Jiffy Lube. This magazine is read by a lot of people, and we're on the back cover or inside front cover. We have a television commercial, local TV news stories done at the hospital on patients. We've done a 55 plus. It's just a community educational seminar that we do at the hospital. Brian Journeys is a quarterly magazine that the hospital sends out. Has very broad coverage, and we do patient interest stories in that. We even had a booth at the College World Series in Omaha, handing out brochures for the Tenex. Patient testimonials are great. You can put those on your website and use those in talks. And then we also have brochures and posters that are in all our waiting rooms, and we give those out to the offices that we visit. And then the last thing we tried was videos in some local health clubs. This is just an example of our Tenex ad that we used in the newspaper. We currently use in the newspaper and the Women's Edition magazine. These are a couple patient interest stories, and kind of an advertorial that we used in the Lincoln Journal-Star. We were able to go pay 50% with Brian in this and defray the cost in that way. So these are nice stories. This is a trifold that brochure that we made with Brian, again, decreasing the cost. That's one side, and this is the other side. We also made posters. This is a poster we received from Tenex. This is a company poster that we just added another piece at the bottom with all our information to make one large poster that we can hand out to any of the offices that we visit and display them in the hospital. And of course, you need to have a dedicated Tenex page on your web page with all the information and testimonials. And the other category would be referral source marketing, where one of the first things we did was I proctored a didactic course in cadaver lab for the orthopedic surgeons in town. And we wanted to let them know we want to work with them. We're not competing with them. And so we wanted to let them know about the technology, if we could help them start doing cases. And if they didn't want to do the cases or start utilizing the Tenex, then they know where to send the Tenex cases then, where the experts in town were. So that's what we did for orthopedic surgery. We've been doing lunch and learns with primary care physicians, i.e. family practice and internal medicine docs around Lincoln for years. And we just added Tenex to the the list of procedures that we offer, and we try to make it to every office within a 1 or 2 year cycle. We visited physical therapists, exchanged our brochures for their referral pads, and we also had a standing offer for any of the physicians or the physical therapists to come in and watch Tenex case, or if they had a patient they were following, I'm happy to have them come watch. We also sent postcards to all the physical therapists in the entire state. We combined that marketing effort with Brian. We also do the continuing education seminars for physical therapists, so they can come listen to you talk about Tenex and get CMEs. And then ground rounds. You can give a ground rounds talk to your physicians and get the word out that way. This is just an example of one of the postcards that we sent out to every single PT in Nebraska. So then we can track how the patients learn about us on our intake forms, and this is what we came up with. 30% still heard about us through the newspaper. Interesting, only 1/5, 21% of the referrals came directly from physicians, and then the rest were kind of distributed among word of mouth, family and friends. 12% from internet search / website, 8% TV, and then in hospital newsletter or employee word of mouth, 7 and 5%. So why should you add this TX1 to your practice? Really, I truly believe there's no specialty that has a skill set that is better suited for this minimally invasive ultrasound-guided procedure. It's a very safe procedure, and it's very effective. So you can treat patients earlier and shorten their recovery time. And typically, you'll see these patients that come to you, they'll have a long list of therapies that have tried and failed, and you'll be the one that can step up and get it done with the TX1. You can provide a great service to them. What did we learn? 80% of the referrals are not from physicians. I just stress that. Physicians always ask, where are we going to get these patients from? And you do your marketing, and you saw the list earlier. It's only 1/5 from the docs. The rest are really a result of what you do with your marketing. The videos in the gyms are the only thing that really we didn't think worked. I think people go in the gym to work out, and they're not looking at the screens. Haggle. I stress that too, because a lot of times you go out and try to get prices for whatever modality of marketing, and they say it's That's the lowest price they can give you, and you know, I can tell you we do try to haggle, and we have got things for half of what they initially started for. And then partner with your hospital. You're both going to benefit. You know, you can decrease your marketing costs by half doing this. Social media, that's one thing that we haven't really delved into, and it's the very next thing on our marketing list that we're going to get into. And then just like anything else in life, you will get back what you put into it. So again, you need to ask yourself, how are we going to keep up with these patients that we're getting? Not how do we get them? We had to add clinic days. We went from one clinic day a week to 2 and sometimes 3. We also have a slot for a same-day consult / procedure where they can come and get the consult and the procedure together. That frees up more clinic days, and that's worked out very well. And typically for patients that you know are chronic patients, and when you see them, you're not going to probably have them do any conservative PT. You know, they're not the more acute patient. They're definitely the chronic ones. And then you may have to hire another IR. And that's what we did this July. So, I ended this slide being from Lincoln, Nebraska. You know, if we've been this successful in a state where cattle out number of people, and our stadium is our 3rd largest city on Saturdays, you can definitely build your practice with this procedure, and you'll feel a lot of you'll have patients thank you, and like I said, it'll be tough to keep up if you do it correctly.
Dr. Budler, first question here comes from Dr. Fuentes. Do you routinely use NSAIDs post-op or during the recovery period?
That's a good question. I usually do not use the NSAIDs. I guess I don't want to blunt the healing response to them. I usually will tell them they can take a Tylenol, and then I actually will give them a script for some Northo for breakthrough pain, but in general I don't have them take NSAIDs.
Great. In terms of a patient presenting with a specific condition and the day of procedure, if that patient should be on anticoagulants, do you proceed with the procedure?
I usually, if they're on something like Plavix or Coumadin or Xarelto, I usually have them hold that. You know, if they're on an aspirin, I probably wouldn't hesitate to do the procedure.
Next question from Amar Malik. How long should you activate the microtip for the elbow versus the Achilles versus the plantar fascia?
So you're talking about ultrasonic energy, the time that we use that. Now for elbows, I feel like the common extensor and the common flexor, you should be able to adequately treat those with, you know, I don't like to go over 2 minutes usually for elbows. I feel like it's such a small area, you should be able to take care of it in 2 minutes. And although if there's chunky calcification, you know, you can add another minute or 2 there because it's just going to take longer to clean those out. Plantar fascia, average time for plantar fascia probably 3 to 4 minutes. And Achilles, those can vary a lot. You know, I'm probably one of the more aggressive physicians that use the Tenex. I can say that I've used up to 32 minutes for a very, very severe Achilles at the insertion with significant calcification. I don't go after the spurs. I'm talking like intrasubstance calcification, and gotten great results with it. So you know, I'll go up on Achilles, but I still would say stay in as long as you need to remove that tissue. But it's been safe thus far.
As a follow-up to that, doctor, how do you know when you've gotten rid of all of the diseased tissue?
I think it's very important to get a mental picture of where all your degenerative tissue is in whatever anatomic part you're working in. You want to scan in both planes and have that mental picture, because it's going to change after you localize it with the anesthetic, and for that reason. But also be systematic in when you treat the area and work from one area and go through it, so you know you've been there, because you'll see the hyperechoic area right after you remove that degenerative hypoechoic tissue. But then with time, if it's taken a little longer, that hyperechoic area will become more hypo or less hyperechoic. So yeah, it might be a little more difficult to distinguish if you've been there. You just have to know you were there, you treated it, and then keep moving on. And so that's how I would do it.
Great, thank you for that. Next question. If you're starting from ground zero, how would you allocate your marketing budget? Referring physicians, direct to consumer, you know, those avenues. Where would you go first?
I would say, given the, it's going to vary a little bit, as far as where you are in the country, possibly, but I think that I would really get the word out there to the public. As our intake form shows, only 1/5 of them are from docs. I'd say definitely don't leave the docs out, but I would do them at the same time. I'd market to the physician groups that I told you, but at the same time, I would definitely get the word out to the public, and the first things that we used were TV and newspaper.
Great, thank you for that. In terms of the initial approval at your hospital facility, how did you, what did the protocol entail, and what are some of the pearls that you could share with the group in terms of getting through that in a systematic fashion?
It was actually very easy for us to get a hospital approval. They did ask me to meet with the board, and we talked about the procedure, and it really is just a minimally invasive image-guided procedure, similar to an ultrasound-guided biopsy or procedure of that sort. And so the hurdles here were very low as far as us getting approved and getting it going. I'm not sure what else I have to add. It was fairly straightforward.
Certainly. No, I appreciate that. The training involved that was provided from Tenex, can you talk a little bit about what that entailed?
So when I started these, I just had Jared Powell, our rep, came, and we did a couple plantar fascia cases, and I didn't have a cadaver course or anything like that. He just came, and he was there for those 2 cases, and I wanted to see how they responded. And when it was a very positive response after, I think it was maybe a month and a half, 2 months, because we wanted to follow those patients. Then we had patients that had it was a common extensor and an Achilles, and actually Dr. Gill came out and again was right over my shoulder watching me. We did those 2 cases together, and then we were just off, and we just took off, and we're very confident going forward doing cases, and I think for an interventional radiologist, with all your ultrasound guidance that you do, this is going to be a fastball. This is a very easy procedure for you to perform, and you should be very confident that you can proceed very safely and help these patients.
Great. Can you talk a little bit to the training that you provide for other physicians who may come to observe cases at your facility?
Yeah. So we will try to set up anywhere from 2 to 4 cases that day. We'll go over a didactic slideshow talking about the Tenex procedure, pre and post care, and then they get a packet. I'll talk about the packet last, but then they will observe the cases, and sometimes it's a same-day consult, so they see how we do the consult with the patient too, and that's always helpful. But then they do get a packet with basically all the material that we use from the initial consultation that we give them for post-op care, and we give the whole thing to them. So it's pretty much everything you need to have to start your Tenex practice.
Great insight. Thank you. In terms of cultivating your orthopedic referral network, how did you approach this physician specialty to make them feel that you were not stepping on their toes, if you will, with regards to these types of patients and these types of conditions that you were looking to treat with Tenex?
Well, we decided early on that we really needed to include them and to work with them rather than to be an adversary. And so we put our slide deck together and went basically to teach them and tell them, this is going to be how we treat tendons in the future. And this is coming from, when you say Dr. Morey, Dr. Bernard Morey, orthopedic surgeons listen. He's he's one of the most well-respected orthopedic surgeons in the world, and they know him, and he believes in this. So when we went there, they listened, and we did the cadaver course, and I think it's good to have them have their hands on it and see exactly what it is, and try it. And honestly, I don't think, in general, orthopedic surgeons are looking for these minimally invasive ultrasound-guided cases to do. They certainly can do them, but that's really not what they're trained to do. They like to operate. They like to do knees and hips and bigger cases. So there are a few that use the Tenex, but I think the majority would rather just give this type of case to us.
Great, thank you. Another question, do you require any imaging prior to scheduling the procedures?
No, we don't. We image on the day of, and I think when you have a very good physical exam and you have a good clinical history, that the only thing you need to do is ultrasound and make sure and document where all the degenerative tissue is. But I am a firm believer that you do not usually need to get an MRI before.
Great, thank you. Any tips for those individuals out there who may be somewhat new to ultrasound in terms of getting themselves trained, coached up on the technology?
I think ultrasound guidance is, I think you're just going to have to get used to it. There is definitely a learning curve with using the ultrasound guidance, and I approach every case the same. You know, I would say before you ever even put an ultrasound probe on any part of the body, that you palpate and mark with a marker exactly where the pain is. So you have a good idea of where the pain is, and then you use the ultrasound. And invariably, that's where you know, that will help kind of ferret out which areas are the areas of interest. But you know, I think that's just something that you're going to have to get good at ultrasound. You're just going to have to ultrasound. I mean, and ultrasound in both planes. That's the one key, I think, is get very comfortable looking in both planes and getting familiar with the anatomy in each plane.
Fantastic. Thank you. You've mentioned in your presentation that you have done a lot of outreach to the specific referral sources, physical therapists, primary care, so on and so forth. Do you believe you would be where you are today in terms of your patient volume had you not gone out and personally introduced yourself and the technology to those groups?
I think it's still very important to go out and into the community and into the primary care community and introduce them to the Tenex as well as the other procedures that you perform. You know, this is a talk about Tenex, you know, marketing for a Tenex practice, but you know, this is all marketing that we had been doing and we're doing for other procedures before Tenex ever got here. So we just kind of added Tenex into the mix and then tweaked it a little bit. But I think, yeah, I think it's definitely good for interventional radiologists to get out, or you know, whatever type of physician you are, to get out to the primary care docs to let them know what's out there, because they're very busy. They see a lot of patients, and it's hard to keep up with the newest technologies. So if you take an hour out of your day to go talk to their staff, talk to them, and let them know what is new, what you can do, I think it's very helpful.
Great. Thank you. A few more minutes here. I think we got time for a couple more. How many procedures did you perform before you felt comfortable and confident with the technology?
I would confident after the first two plantars. I was very comfortable with plantars. I mean, after having I think elbows were probably, it's just an area that we're just not really used to working in as far as interventional radiologists. We were just a little tentative for that. And I think it maybe took 3 or 4 cases to really feel confident, but comfortable. But I think that it's a very short learning curve. I think with someone that uses ultrasound all the time, I think this is a procedure that you can become very comfortable with very quickly.
Great. From a post-procedure standpoint, how often do you see your patients after the procedure?
So initially we were seeing them at 2 and 8 weeks, and then we just didn't feel like the 2-week was necessary, and we kind of went through that with our vein patients as well. And so we quickly went from 2 and 8 weeks to just 1 visit at 4 weeks, and then so we just see them once at 4 weeks, and if by 8 weeks they're not feeling better, we tell them to absolutely call us. And so essentially it's 4 weeks and then PRN, and so sometimes we'll see patients if they need to a second time.
Thank you. In terms of the post-procedure protocol for your patients, can you by body part highlight a few key points in terms of the ramp to activity, the booting, so on and so forth?
So yeah, so I treat the plantars and the Achilles very similar. They're booted for 2 weeks, and then they're free to go to their most comfortable shoe after those 2 weeks. And after the 2 weeks, they can start to gently stretch their Achilles and their hamstrings, like against the wall, that type of stretching. And of course, the whole time afterwards, we have them kind of write the alphabet with their foot when it's not in the boot those first 2 weeks. And after we see them at 4 weeks, they can slowly progress to their normal activities as they see fit. Usually the Achilles or the plantar fascia will let them know if they've overdone it. Now for the elbow flexor and extensor, we really tell them the first couple weeks we don't want them to even carry groceries, just range of motion. And after the 2 weeks, then they can slowly start to do some of the daily activities, and then that just progresses after the 4-week visit. Again, we don't want them to do anything like lifting weights or getting into their exercise routine until 8 weeks, where it's feeling really good with no pain. Now the patella is a little different animal. We usually will have them non-weight bearing and in crutches for the first 2 weeks, and then after the first 2 weeks, another 6 weeks, they're walking with no brace, but no brace or crutches, but they're walking just on level surface. We don't want them to go up any stairs or load that patellar tendon, because their negative feedback is gone. That degenerative, painful tissue is gone, but that tendon's still a little bit weak. So that's why we don't have them load that. After the 8 weeks, they can start to load it and go upstairs. And I probably wouldn't have them get into any exercise for like sports for more like 10 or 12 weeks after that.
Great, thank you. A follow-up on the foot and ankle area. We have a question from Dr. Michael DeVito. As a podiatrist, we use a lot of orthotics post-procedure as well as nice splints stretches. Are you advocating this to avoid recurrences of fasciitis and Achilles?
I've told the stretching that we have them do prior to. I tell them that they really should continue with those stretches, and I wouldn't see any reason not to use their night splint. But I would, I guess I haven't told my patients that, oh, you need to wear the night splint after the procedure. I have told them that they need to do all those stretches that they were doing before, so that they, can keep it loose and supple.
Great. We're coming up here.
Sorry, and I wanted to add one thing is, as far as the orthotics, what we tell them, because we get that question all the time, should I still wear the orthotics, and they're expensive, and I say, basically try the shoe with orthotics and without orthotics, and whatever feels best, you do that. So if it feels better with orthotics, wear them. If it doesn't, then I'd say wear them, but keep stretching.
Fantastic. Last one here. From a logistical standpoint, where exactly do you do the procedures, and then what does the setup, procedure, and discharge time frame look like? We perform all, or I perform all my procedures here in the hospital, in the radiology department. We have a multi-purpose room. I do like the multi-purpose room because I can angle the bed, and any which way I would like. And from a discharge, well, if it's a patient that's coming straight in for a consult/procedure, you're looking at probably an hour for the whole thing to be done, unless it's a really involved Achilles. That can take a little longer. But for
patients that's been seen in clinic to come in, get prepped, get done, and then out, you're looking at probably 30 to 45 minutes.
Got it. Okay. Well, great. Well, Doctor, we're at the top of the hour. I want to thank you very much for your time this afternoon. This has been fantastic. Before we sign off here, wanted to leave it open for any last comments that you may have.
Well, you know, I want to thank you for allowing me to talk about our experience in Lincoln, and I can't stress enough the importance of you know, not worrying about where these patients are going to come from, as far as you know, where am I going to get these referrals from specifically, because you know, going into this we thought the same thing, but when we actually looked at the numbers in the intake forms, only 20% were from referring physicians. The rest are patient-driven. So if you do your job marketing, you'll definitely get the patients. And so you know, you have to spend a little money to get them, and you'll be rewarded, and as will the patient.
Great. Thank you for that. Well, again, thank you for your time.